check it out. How was that exercise yesterday? Good. Well, today we get into the sixth session, and so there are a bunch of interesting and relevant features here. Did you get her, Craig? Good. It's just that if we have visitors, I want them here when we start, not coming in part way. It disturbs my field. So sixth session. You know, we've been walking around this circle, as I said before, you know, taking these different viewpoints on the body, and in each one sort of trying to highlight certain features. Well, of all the sessions in the first 7 cycle, 6 is the biggest session in terms of the territory that it covers. So when I learned this stuff, it was, whenever I was scheduling a 6th session in my appointment book, I'd always allow extra time. Over the years, I was able to narrow it down and begin to understand that if I could make choices, that I could keep the session within time boundaries. But that if you try to do everything in a 6th session, which some of you may, you're going to be there a while. So having said that, also realize that like the 4th session and the 5th session are one session broken into 2 parts. In my understanding, the 6th and the 7th session are one session broken into 2 parts. The continuity between 6 and 7 is a little harder to see initially, in the sense that they seems like you're dealing with opposite ends of the body, 7 being primarily about the head, 6 being primarily about the sacrum. But nonetheless, 6 sets up 7. And so, in a way, I have to talk to you in a bit of a circular fashion around these 2 areas. Because what you're dealing with fundamentally is the polarity in the spine in 6-7. You know, the downward pole and the upward pole. So at the 6, your main focus, like 2, is primarily about the spine, but you go in through the legs. 6 is primarily about the sacrum, but you go in through the legs. So then we end up saying, oh, wow, we have to know a whole lot about legs, and we have to know a lot about sacra, and we have to know a lot about the pelvic girdle in general as we close in on 6th session. So you have legs, sacrum, pelvic girdle, the 3 sort of primary elements of 6. So everything that's been said up to date about legs is sort of in the information side of the equation. That's the leg stuff. Things that we've said about the sacrum: the side bending action in walking, the side bending counter rotation, the alternating diagonal axes. All of these elements are here in your hologram of information about this whole region. So I won't go over those too much except to refer to them in passing, but I want to kind of zero in on some things about the sacrum and the relationship to the ilia that I think are very relevant to this session. We talked about sacrum biomechanics in relation to the ilium. Now I want to talk to you a little bit about ilium biomechanics in relation to the sacrum. It ain't the same thing. And the root concept in understanding this is this fundamental notion that the sacrum plays a bipolar role as part of the spine and as part of the pelvic ring. So it has these two distinct domains, if you will, of normal function. So I've talked a little bit already about sacrum on ilium, so I want to kind of focus on ilium on sacrum here for a few minutes. One thing you need to sort of understand is that in normal walking, the ilia counter-rotate to each other with the gait. So as the push-off leg is in that phase, the toe hinge is flexed, and the kinetic energy is driving through that leg to move the body forward. The ilium on the same side is in its most anterior torque position. And at the same time, because opposite the push-off leg is the heel strike reaching out, that ilium is in its most posterior torqued position. And these two ilia then are in counter-rotation to each other at that phase of the gait. Then as the push-off leg leaves the ground and begins the knee swing forward, the ilium unlocks from its anterior position and begins to float until it is essentially ready for the heel strike. The ilium is all the way back. So the ilium mirrors the swing of the leg in its normal walking gait. And you can think of this in a way as like a spring being wound and then unwound. So the winding is the cocking backward as the leg goes for the heel strike. As the weight goes under the body and the locomotion drive starts to move, that ilium is following that motion, and just at the push-off, the ilium completes its anterior torque, and you actually get a motion that's the equivalent of like throwing, where the hand snaps on the release of the projectile. So these ilia then add a little bit of mechanical advantage to the push-off. Now, you know, I talked to you a little bit about internals and externals and the different configurations in the pelvis. One of the observations is that in the biomechanical forward and backward bending of the sacrum, that the internal had a greater range of motion, and the external sacrum ilium tended to be a tighter locked joint. Internals have greater motion, externals have less motion. Make note, these are clinical observations. This is not backed up by research. This is stuff from the internal-external model, none of which has been validated. But having said that, my observation is that the internals, part of the reason that they're more agile, quicker on their feet in general, is partly because of this ability to drive those ilia a little faster and farther. so that when they push off, they get a little bit more mechanical advantage than an external who doesn't have the same range of motion of ilium on sacrum. So this is to, in a sense, inform you that when you're working with different types of people, you have different expectations. You expect to see an internal have a longer push-off than an internal. Excuse me. Did I say an internal having a longer push-off than an external? So when you consider this counter-torquing of the ilia in walking, combined with what we described as the side bending and counter rotation of the sacrum, which has to do with its combination of physiologic and biomechanical activity, you begin to, again, have a deeper appreciation for the complexity of this zone and why particularly bipeds have so much built-in potential for trouble here. And why, as a Rolfer, your developing skill and understanding with managing this area is vital to your success. So there are some key relationships between the pelvis and the legs that we look at in 6. And you can put these, put them on a kind of a separate page, because these are your primary elements. I'll be talking more generally about theory stuff as we go, but have a place where you can kind of download the list. Somebody said they liked those lists, so I'm going to go out of my way to try and get them in list form. The first, point of observation in pre-6th hour diagnostic eyes is tilt of the pelvis. You're back to that equation again. Is it an anterior or posterior tilt? And as soon as you make that observation, you also then know whether your 6th hour starts with the anterior superior spine or with the hamstrings. Obviously, anterior superior spine, anterior tilt. Posterior tilt, hamstrings. Okay, this is not part of the list. This is general notes. The thing about primary and secondary tension, if you looked at a pattern where you saw someone with a posterior tilt, and you knew that the hamstrings are the primary shortness or primary tonus that is keeping the pelvis in that posterior tilt, then what do you do about structures on the other end? So in this case, it would be structures at the anterior superior spine that were on hold. Not everything that goes wrong in the body is always about shortness, but it's very often about a lack of responsiveness or an inability to go through full range of motion. So a structure can be on hold without being short. It can deteriorate and lose elasticity without being mechanically short. This is vital. I grew up thinking that everything that was wrong was short, literally short in distance between 2 points. I came to get that a muscle or fascial area can be non-functional and still have normal length. So when you see primary shortness, your eye needs to look for what is holding against the primary shortness. It may, in fact, look longer, but it can't balance what is driving the pattern. In a sense, you might have one muscle simply dominating another in the reciprocal tonus of the two structures. So you got the primary and the secondary. And understand that the word shortness is euphemistic. It doesn't necessarily mean length short. It simply means it ain't responding well. It may be motion restricted. But I just want to drive it home. Short ain't always short. So, here you are looking at pelvic tilt. If you're an anterior tilt, you've got primary work to do at the anterior superior spine to keep releasing the primary actor in bringing the pelvis anterior. Remember also that the iliacus, because it goes from the pelvis to the leg, also gets involved in anterior tilt patterns as a primary shortness, quote unquote. So if you see anterior tilt still looking at you pre-6, you may have a segment of the session happening right here, right back to this territory. We were there in 4, we were there in 5, you could be there again in 6. And your client begins to think you're pretty relentless about this time. But you don't make a big deal of it. You just go in here and it's a couple of moves. It's not on and on and on and on. You might be giving literally 10% of the session to this. Conversely, if you've got the posterior tilt, your first opening moves may be directly to the hamstrings. Put your client face down. This is a new approach to hamstrings in this unfolding of this series, but I'm guessing that Trish gets it, so you'll get to see it. Essentially, it's again a matter of just getting the medial and lateral hamstrings better related to each other. So here, if you've got an internal, you've gone to the medial hamstring. If you've got an external, you've gone to the lateral hamstring, sort of relentlessly. In this session, you don't go so highly specific about internal, external, but you work to get the hamstrings themselves related on those two quadrants. So now you're taking the sort of that segment of the leg, and you're not trying to debug the big pattern, but you're trying to get the relationships better organized. And as you do that, you will release the posterior drag on the pelvis, and the tuberosities will come out from under a little bit. So that's sort of your target entry. If you have chosen the anterior superior spine, you still have work to do on the hamstrings because they are holding against the pattern. If you took the hamstrings on because of a posterior tilt, you still have some work to do on the ventral side because it's holding against the pattern. But the distribution or proportion of where you put the work changes depending on how you see the pattern. In a sense, the one that's holding against the primary shortening is going to be a matter of tonification and rendering active, not so much just lengthening or separating.
So, my question is there anything technically you can do that will distinguish between lengthening, sort of separating touch, and just activating? And how do you make that?
Well, differentiation, let's say differentiation is one of the things we do, which is where structures that lay parallel to each other have become sort of joined by fibrous adhesion and clumping together. There are also surface deep relations that we need to differentiate. But most differentiation technically has to do with getting your fingers in between things and prying them apart. Peeling layers, like peeling the skin off of an orange, or, as I've said sometimes, scraping paint with the back of your fingernails almost, like pushing a layer off of another one. Tonification or sedation would be accomplished probably with techniques that to the outside observer would not look very different from one another. But most often it would be leaning on something and kind of working back and forth. Let's say you were right here at the anterior superior spine, your client on their back, and you might lean right into that with a flat elbow and start like rolling, like a rolling pin, but very slow back and forth across those tissues, or putting a load into the tissue and waiting until you feel that quiver and the chaotic response that precedes a reorganization. That's very different than separating structures that have become adhered to each other. So technically, they look different. If you put your elbow in parallel the fibers and start going in there and literally pulling things apart, then you're back in differentiation again. So how you put your hand in and the concept of separation of overlapping areas or just simply changing tonus broadly are very different technically. Anyway, I guess one of the target goals, this goes back on the list side, you look at your client before the session, you're looking for anterior-posterior tilt. One of the other things you're looking for is the relationship of the calcanei to the tuberosities. In theory, the closer you can get the calcaneus to be directly under the tuberosity, the better the biomechanics of the system. But how do you get a calcaneus to move? Whew. Well, there are various tricks and techniques, some of which we've started to introduce, the various ways you hang on to the calcaneus and try to pull on the ligaments that join it to the talus. Those are the very local sort of tonification of ligament structure so that there is some adaptability available. But one of the big drivers for calcaneus orientation are the gastroc and the soleus. Because the soleus crosses two joints as it comes from the deep compartment of the leg. I guess it's not actually the deep compartment. The deep is the tibialis posterior. Anyway, when it comes from the back part of the leg, the soleus traverses both the talus tibia posteriorly and the talus calcaneus. So soleus is a very important orienting structure for the calcaneus. And the gastroc crosses three joints. The two aforementioned talus tibia, talus calcaneus, and the tibia femur. So your prime movers, attachments on the calcaneus to the lower leg and then across to the upper leg, are these posterior structures, the gastroc and the soleus. So 6th hour, sort of turns the body and leaves you looking at the back. After you've checked out the tilt of the pelvis and tinkered with that a little bit, then you've rotated around and you're looking calcaneus to tubes. And it's those geometric lines that form the root of your 6th hour approach. That is a lot of territory. You know, if you've started at the anterior superior spine and you've done some work here and you maybe gone down and even said hello to the front of the talus tibia zone here, it's certainly kosher in a 6th hour to even get into the soles of the feet again, the plantar fascia. Because interestingly enough, if you put someone face down and look at them from foot headward, you can begin to see how the foot shape reflects the use pattern of that whole fascial array in the sole of the foot. It tells you how weight is driving through that foot. And preparing the foot to receive a different organization from above is one of the rationales for working in the plantar fascia. So it's not just straighten it out. In a sense, it's always a preparatory move. You know, you don't make the foot perfect, but you open the foot up to readapt so that when you get these changes from above, the foot can take it and accommodate. So here you've got this view where we'll get to take a look. I'll show you on Trish, you know, how you look at the soles of the feet and kind of look through to the pelvis. Say, how do the feet reflect what I'm seeing up here in the pelvis? These are esoteric viewpoints. This takes a long time to get good, but I'm just trying to point you down the road and say, make observations along these lines, because essentially you become a data processor. You after you get a few hundred bodies behind you, these things start making sense. You know, you look at a foot and you go, "This, no way, I got to get into this foot. I can't leave it the way it is." Other feet, you look at them and you go, "These are good feet. I don't need to do a whole lot here. Just open the system." So anyway, we're looking at calcaneus to tuberosities. Essentially, you are looking at the support system of the lower girdle in relation to the sacrum. And if you get those parallel lines, if you get that geometry in, that 6th hour, what happens is the sacrum starts to be able to float and really behave like spine. When you have calcanei that are either lateral or medial and driving forces off axis at the tuberosity, then the sacrum is always getting locked up between the ilia, and it's trying to behave more like pelvis. So your long view in 6 is you want to leave the sacrum truly behaving like spine and unbind it from behaving like pelvis. This is serious stuff. Now, you may never see it in some individuals, but that's your hallmark. That's what you hope to see. That's what you work toward. So in our listing then, calcaneus to tubes. In our sort of technical conceptual, it's hamstrings. It's how the gastrocs and the hamstrings cross at the popliteus. We want to see a relatively symmetrical diamond shape appear at the popliteus, which is defined superiorly by the hamstrings and inferiorly by the gastrocs. Can you see that in your mind's eye? So another feature of 6 is your detail work around the sacrum. There's a French osteopath who's done some beautiful writing about the sacrum, Marcel Bienfait, Bienfait. 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 Marcel. Unfortunately, he writes in French. And I've struggled through Bienfait using my Spanish and Portuguese. But, you know, it was enough that I could get my teeth in, because all the muscle names and stuff are in Latin, and, you know, so you know what he's pointing to. And, in any case, Bienfait really takes time to elaborate this concept that you must come to understand the sacrum as floating in the waterbed of the two articular surfaces. These are synovial joints. And you imagine that the sacrum actually rides on this pillow of fluid between the ilia. And it's suspended like with these ligament arrays. And the primary ligament arrays that you're concerned with are sacrospinous and sacrotuberous. And you remember that I said that they're different in name, but when you get down to it in terms of clinical application, there isn't a whole lot of difference. But it's the lower pole of the sacral ligament attachments into the pelvis, into the ilia. And the upper pole are the sacroiliac and the iliolumbar array. So between them, those are the suspensory ligaments that the sacrum kind of hangs in while it glides on the waterbed of its articular surface. It's elegant. Now I'm just going to give Stanley Hoppenfeld a couple of kicks here. I mean, this is the manual of orthopedic diagnosis. This is a big, fat, in-print, currently used textbook for orthopedic doctors. The sacrum does not articulate on the ilium. Contrast to Bienfait. It floats, it's locked. Hoppenfeld describes it as a syndesmosis, which is a tightly packed, non-articular junction. Cartilaginous gracilis. I just keep harping on Hoppenfeld really to make sure that you understand that the things that you're learning about sacral mobility and motility are not in the common lexicon of the medical community. And that if you say to a classically trained doctor or orthopedist, even more so, that the sacrum was side bent and rotated and that's why the patient had all that back pain, you are the quack. Right or wrong. So, you know, this is politics. And you have to know where you stand in your understanding, and you also have to know where you stand when you open your mouth. They may not be the same thing at all.
So it's the only when you move, you know, not to play. So just say, like if I, let's say I have a client situation, talk about it, he goes, well, what did you do?
I worked on the muscles. You know, got the whole pelvis better balanced over the femur, you know, decompressed the discs in the lumbars by lengthening the muscles and the ligaments. That's kosher. That's enough. You know, they don't really want to know what you did anyway, except the rare, curious individual who really wants to know. But you should know. You know, but we do get to touch, you know, because we are outside the system, because we are essentially not financed by the medical insurance loop, you will get people who have reached the end of the limits of that kind of therapy who are now casting around in the alternative realm to try and get help. And sometimes they have a little, maybe a little money left over from an accident settlement or something like that, and those insurance companies want your treatment notes. So the treatment notes that go to the insurance company are sometimes, well, mostly they're reviewed by, teenage bureaucrats. But once in a while you'll have a medical review on one of those cases, and you may even be called into for a deposition. And this is really the point that I want you to be clear about. You don't show off about sacral mobility. Just keep it simple. Even if it's how you get it done. So, and these ideas are changing, but it takes 15 or 20 years for a new idea to hit bottom in medicine. Bottom being where the people are being trained. So these ideas have only been around 50 or 100 years, At any rate, here we are at 6. And sort of the primary job then is to get these parallel lines organized. And here's a little quickie drawing for you. The center of a circle is just that. A circle has one center, diameters same all the way around. One of the characteristics of an ellipse is that it has 2 foci. So, in a sense, your 6th session, since the body is elliptical in form, your 6th session has to do with getting these lateral vertical axes organized, which are the foci of the elliptical geometric form that we are. So this is your tuberosities hit here, and your calcaneus hits here. That's what you're looking for. When you watch someone track, you're looking to see how the heel, the tube, the nipple, mid-clavicle all stack as that person comes toward you in movement. That is the support available for these alternating lateral vertical axes. So in a sense, that's part of the palintonic principle as you apply it to this 6th session. It's how you get from anatomy to geometry. At one point, Ida Rolf described the 6th session as the session of the rotators. So, as I described the ligament spread from bienfait, you also think about how the rotators suspend the pelvis and the sacrum on the legs. How that array comes off the head of the trochanter like a series of suspensory springs heading up toward the pelvis, and some of them literally traversing the pelvis into the front of the sacrum. That's primarily the piriformis.
So what did you say, how do the rotators suspend the sacrum?
Suspend the pelvis and sacrum on the leg. So, you think of the piriformis as the dorsal psoas. Because it traverses the pelvis from the femur, much in the way that the psoas traverses the pelvis from the lesser trochanter across the front. The piriformis traverses the pelvis from the greater trochanter from behind to attach to the front of the sacrum. Traverses means it doesn't attach to, but it crosses. So if you think of that psoas piriformis, you have to get that relationship in order to get the pelvis to float on the head of the femur. And then you have that the obturator internus, which is the analog, the dorsal analog of the iliacus ventrally. So you're playing balance of obturator internus and iliacus on one hand and piriformis psoas on another. Soon. So that's sort of the muscular suspensory array around this joint. Getting that ilium on pelvis and ilium and leg to spine, those two sets of relationships. The detail stuff in the ligaments, remember we talked about ligaments being fairly slow to respond. Generally, your ligament work is a matter of technically, Nuria, parking on it and waiting for it to change. Muscles, you can kind of roll over them and pull at them and express the tension in them in a way. But with ligaments, you simply have to get down, get your weight to bear, and hang out until the tendon organ structures, till those little spider receptors literally give up. And then you'll get tone change in ligaments, but they're slow. That's the main thing to remember. So if you're in the ligament bed, you're not going very quick. You can, move a little more actively through muscle tissue. It's more responsive.
Are ligaments more slow to go back to their old pattern then also? It seems like muscles tend to go back.
I think if you get a state change in a ligament, it's probably more stable than changes in muscles. Now, having sort of crossed this junction here, now, you're up in the spine. And remembering that there's a lot of this session, which is about setting up 7, you sort of have come up out of the legs across the sacrum, and now you're on the straight highway to the head. So here we take a look at the curvatures and side bending stuff of the spine, and we begin to take that on with a little bit more intention here. All the stuff that we've said about spinal biomechanics comes to bear here. Side bending rotation, the wide or narrow erector patterns that go with inhalation or exhalation types, or the distribution of anterior-posterior spinal curves, thoracolumbar junction. All this stuff is now in your sights in 6. So you could see that you look at a spine in 6 with this view and you go, oh my God, I could spend a whole hour here. Or you could have spent the whole hour just around the pelvis and the rotators. Or you could have spent another hour in just getting the legs in shape. So this is in a sense, a 6th session is an exercise in restraint. And in really sort of anchoring in your target for the area, getting it done, and keeping moving. If you fuss around in 6, you can be out there an hour and a half in nothing flat. And at about 50 minutes, your client is exhausted. People have limited resource for uptake of manual therapy, the stimulus of the kind of work we do. So with this much territory looking at you in 6, again, you have to make your judgment calls about what you're going to do, not going to do. I've seen 2-hour sessions in training classes. And you have your client getting off the table, your practitioner partner, looking like they've been run over. And then, oh boy, we're getting a 7th session in 2 days. So I'm just saying this is practical. When we do this session here in class, I want you to exercise restraint. When we do the analysis, we'll try and pick the key areas for the session based on our previous experience with you guys. You know, what were the main events, and how we'll focus this session to get the most benefit for the individual. But what I'm doing is saying the map is big. What you encounter in the territory, you're going to have to be selective or you're not going to get it done. 2 questions.
Have you ever had someone with so much to work on that you just said split the 6 up and we're going to do it twice?
Many times.
And other question is, if it's not too much, is there room in like 8 and 9 to go back and clean up that stuff?
Yeah. Well, both 8 and 9 you can cross this territory again.
In terms of your working on Trish and this being a really big session, could you show us some of the stuff that we haven't seen, gastroexfoliate, that?
I will, to the best of my ability, I will show you the blueprint. In this case, Trish serves as, you know, this session is for you guys, as more than it is for her. I'll try to get her enough in it so that it serves her. But it may be slightly immoral to say that it's your session, not hers. In any case, yes. So, I'm not going to belabor that spine stuff too much. We've already touched on quite a bit of it. I'll try and show it to you. Just be aware that it has to do with the spread of the erectors. Remember that if you're working in the spinal groove, you are working between vertebrae. If you're working in the costal groove, where the ribs go behind the transverse processes, you are not only organizing ribs in relation to spine, but you are also getting effects that are going prevertebral. If you have somebody who has any degree of kyphosis or anterior thrust to the neck, like me, you want to make sure that you bolster the body so that having someone face down does not jam their neck backward. With that adjustable table, of course, in the dropping face piece, no prob. You know, you can just let the chin thing down and her head will drop so that she'll accommodate the face down comfortably. But on a fixed height table, you need pillows underneath the client. And once again, I would have to emphasize that in tinkering with these spines and pelvies at this depth, we begin and end here with sacrum and occiput. The neck work that we got yesterday comes right home here at the end of 6. After you've done this work on the dorsum, you're going to turn them over and make sure that the neck is as moving as easily as you can get it. And you particularly want to decompress the cranium off C1. You know, working along that, in those obliques and in the attachments of the trapezius and levator, all along the occiput. So I think that's about it. Make sure that sacrum tracks properly before you let them out the door. So I want to give you a little slideshow just to pop some images. I don't want to belabor it, but just to let you see it again. Oh, hi. I just can leave it in there. to look at this fella. Again, just take a quick look at that iliacus and see how it would be involved in an anterior tilt. Think about how the iliacus would behave with short hamstrings. How it has to put the brakes on and hold against the primary shortening in the hamstrings. Look at the obturator internus there, lining just inside the ilia, around the tuberosities. And the piriformis going in front of the sacrum. And here's your hamstrings. On the left-hand one, God, what is the name of that guy? That big diagonal. Yeah, I forget. Notice there's the diamond at the popliteus. Oh, I missed my pointer. Oh, my God. Look at the diamond at the popliteus and see how it's unsymmetrical in that drawing. This is the territory that is sort of one of the hallmarks. If you can get that diamond roughly symmetrical, you get a knee that operates pretty straight ahead and straight back. So this is a pretty good indicator for order. This is a great picture of the rotator array as well. It's interesting here that here's your posterior tilt and your anterior tilt and normal. And the main thing you want to look at is notice this angle. In an anterior tilt. Here's your posterior. Look at this, almost flat. So this is your extreme internal, your extreme external, and then your normal curve in there. This is an interesting slide that I pulled out because it really shows the inferior pole of attachment of the cervicals at the mid-dorsal junction. And just to balance how you would see that if the ilia are organized properly over the calcaneus, that you get support right up there to that mid-dorsal junction, and you get the array for good head carriage. And there's your side bending patterns in the spine, which are part of normal walking, and also when they get fixed are the root of scoliosis. Sacrum side bent right, lumbar side bent left, and then correspondingly. Now this is your simple curvature. Remember how complex or compound curvatures will have double crossovers in each of those regions. Spinal profiles, same thing. High amplitude on the left, low amplitude on the right. Little zero in here on the cervical erectors, splenius, semispinalis. This is definitely fair game in a 6th hour. And there's a dissection, or rather a drawing of the same territory, not a schema. Look at that splenius. It's really beautiful, which is on the left side, the big sheet covering, how it comes down to about T2. These attachments in here of the splenius are a place to give people a lot of grief, this stuff. You'll find a lot of people complaining, oh boy, is that sore. So when you get in here, this behaves like an aponeurosis in the sense that it's a fascial ligamentous bed in here. And as such, your pressure is not quick across it, but tends to be more like sink in and hang on until you get tone changes in here. You could do this with the person on their stomach if they were properly bolstered. Then there's just a big view of the back just for your, aha, yeah, remember it looks like that under the skin. Yon diaphragm again. It's a great picture. Various obliques. And I've got a great piece coming up here. Where is it? This just shows you the side bending rotation in the lumbars there on the right, and how the quadratus lumborum will act in side bending. It's also a major side bending structure for the lumbars. The TFL. They have it as an internal rotator. Oddly enough, I categorized it as a place you work to relieve the internal rotation of an internal type. But you might find yourself working on the TFL in relation to the hamstrings to get the femur balanced in how it tracks. There's your semimembranosus, semitendinosus. And there's that lateral hamstring on the right lower. That's your spot for the external rotation. And there's that sweet spot into prevertebral. Just the sense of how you get from, from surface to deep. Like into these, if you're working in here, how along the edge of the erectors, your effects can go prevertebral via these fascial planes. Long muscles of the back. This is definitely territory for this session. And here you could be doing a lot of differentiation. Pelvic floor. Oh my God. I'll get back to this drawing, this slide at another time and talk more about it. But notice the hamstrings coming into the tuberosities. So your rami are going to be here. There's your tube. There's your sacrotuberous ligament. Sacrum, there's your coccyx right there. Gluteus maximus. And this is, I lied when I said there weren't muscles inside the thorax. You can't get there, but there they are. This is looking at the inside of the sternum from behind. Transversus thoracis. There's your internal intercostals, which we did suppose were there, but I forgot about this. So this is definitely respiratory stuff. But probably the only way you can get to it is through compression techniques, where you actually put a load on the thorax and wait for the repatterning of these muscular tissues. You can't get your fingers on, no way. Yeah.
That would be the pelvic muscles that are
Yeah, probably adapted.
so that it's like compression, you might use.
Yeah, and with the crural diaphragm or costal diaphragm patterns, these are probably involved too. Okay, let's take a break. It's like you find yourself going days and not noticing that it's gone, because normal is not like that. So the absence of pain is an interesting phenomenon. In any case, she still has some stuff she's working with, her neck and her low back, but she wants me to get back to this right side where it's achy, and I said, well, this session's directed toward the whole back, and explained to her a little bit about how we're working still to build up support for the spine through the legs. So we talked a little bit before the session also about her modifying her exercise routines to begin developing more dorsal tone. It's reported that she still sometimes feels like she's being pulled forward. And I pointed out, you know, that doing a lot of abdominal crunches and flexor dominant exercises tends to create more strength on the front side. So maybe a shift in the exercise routines to build up tone of the dorsum will help with her posture repair as we go along.
Okay.
Take a walk with her, have a look. Trish, can you let her take a photo of you? Just want to get some photos.
Probably.
Beep, 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 beep. Are you getting me? You get sound? Yeah. Okay, good. Any questions while we're waiting? Nope, never mind. So as you watch Trish move just in and around the chairs, what I see is lots more upright carriage and smoother through space. You look good to me. Okay, once more, take the stroll. So we are looking at how the pelvis is set on the legs. We're curious about anterior superior spine and hamstrings and how front back structures are relating to balance her on her legs. And then turn your back to the group for a sec. And I'm also looking at where her heels and her tuberosities line up in terms of these lateral vertical axes. As the lateral verticals come into alignment and these lines work, the center line is going to work better. So that will give her better support for her spine. You can see, if you look at these two diamonds, how there's a tendency for everything to be pulled around like this at the back of the knee. So I'm going to be looking for literally getting the tissue to lay better on the back of the leg as a way to get this whole plane in order. Again, this is for support of, this is leg to ilium, and then for the support of this focus of this ellipse, so the support will come through the thorax.
Could you just point out where her sit bone is right there?
Right there. So you see the calcaneus falls inside the sit bone on this leg. Interestingly how this calcaneus is lateral, this one's straight under the leg, but that one's out from under the sit bone and this one's inside of it. So the sense is both calcanei are deflected to her left, functionally. So I'll be looking to get better order for the whole back of the leg to get them underneath her. And turn profile again. And I think I still have some work to do at the anterior superior spine to keep opening this structure so our pelvis can float more on the trochanter, drop back a little bit. Enough?
No, I just had a small glitch, but it's okay.
Technical? Okay. Okay, so I'm going to start with the anterior superior spine. A little bit of work across the front of the pelvis, pick up some of what we did last time. Then I'll go to the hamstrings just to get a balance front back in that area. Probably do a little work in the iliacus and in the obturator to get that front back related. See how the psoas and the piriformis relate. So we're just going to take once around the pelvis here to start and then go into the legs. So come lie on your back. You can just cover your tummy there so you don't cool off.
No, I'm fine. Thanks. Go ahead.
No, I won't do it again. Fourth floor, sporting goods. How about that? Hiking shoes, exercise equipment. Yeah. There's the pull right on that anterior superior spine. I can feel it right in the tissue. So, where's Nuria? Oh, you're watching the monitor? Okay, well, I was going to talk about the difference here between the differentiation and just sedation. Yeah. So I just want to sedate the quad a little bit so it doesn't drag so hard on the pelvis. Trish, just bend your knee just a smidge. And down. If you just go back and forth across about that much range and real slow, it'll just help this to let go. Mm-hmm. Yeah. Down. All the way down when you go down. You've been going to the gym? Any difference in your strength or aerobic
I
sense?
ran a little bit further with seemingly less effort the other day.
Mm-hmm. Lighter through your legs, or?
Yeah. I was looking for a wider range of motion, I guess.
Uh-huh.
And I think maybe there was a bit of difference. It's kind of hard to tell, though.
But the effort was distinctly easier, or some easier?
It may just be a result of conditioning. I don't know.
Just bend. Remember how you do that? Yeah, there you go. Good. Okay.
I did seem to have more movement in my hips as I was running.
Uh-huh. Usually that equates to a little better aerobic efficiency, because you're just not pushing through as much tension to move. Knee forward just a little. Yeah. Back. Forward. Back. Okay, good. Just a smidge forward. And back. And again. Just keep working right there. That's it. Just feel through. See, when I pull on this one, the whole pelvis comes down on this side. This one's much less feeling across into the spine. Feels like it stops at the acetabulum. Okay, same thing with the movement, just a little and a little. Down. Up. Down. Knee up. Hang on a second. Bring this knee up. Just use that for stability. Now just bring this knee. Now you feel how you're pulling your whole pelvis back to do that? Just push the knee forward. There. You see the difference? Mm-hmm. Down. And knee forward again. Good. Back.
Are you moving laterally?
I'm actually moving straight vertically. Cephalad. Well, the left hand is keeping her leg from going adrift because I'm working in this session to build those lateral vertical axes. So I want to keep her in her relative alignment to that. So when she comes out of the session, that'll appear. If I just loosen her and leave her like that, you won't get the geometry part of it. So you get sort of openness without order. And that's not a great trade-off. Okay, once more, just bend the knee. Oh, yes. You okay with the pressure there? Keep going just back and forth, nice and easy, and you keep bringing the knee straight forward. And again. And back. Okay, good. Okay. Transmits through better. Okay. Now, since she's still, got this right side chronic pain, I'm curious. Now, what goes on here? So part of my question as I put my hands in is to try and find out if there's something there that's shortened up or stopped moving normally. So I'm still on the search for what that pain's about.
Just kind of looking along.
Yeah, going around that shape. Tricia's trying to figure out whether she can let go of that. Right? You don't think so? Right. Well, let's negotiate about that. I can't take it away from you because it would be too intrusive, but I'd like to set up a pressure here that you can soften to and let the layer relax that I'm on. Because this is very much about how your pelvis balances on your legs. Okay, that's good. That's good.
Are you on just on the inside of the rim on like
Yep. Right into the belly of the iliacus. And now she's figuring out how to let some of that go. So there's a really interesting negotiation with her threshold, with how much of that's okay. And I'm really listening for that because I can feel if I start to get over her threshold, her whole system starts going on alert. She's preparing to flee. or to kick me, Now, since this is the pain side, again, I'm curious. And I'm thinking about the arrangement of those two legs, wondering where the support might be disorganized for her spine. See, so I'm into a different piece here. See, it's not the same zone. That's your iliacus this way. And that is the psoas. to the inner side. Right, hello, right there. That was your intestine. Little things squirting around in there. Okay. Yeah, good. That's the front of what hurts. You know, if I go through you, these two hands are only about 2 inches apart. Okay, now just move this leg just a little bit. Just roll it inward for a start. Okay, good. And roll it back out. Hang in there, you're looking good. Roll in. Now that part of her psoas is really tough. And quite different side to side. Iliacus is the main tension on the left, psoas on the right. It matches the way those calcanei are both off to her left. So it's like her pelvis tends to lay into, you know, support on the right side. I think I'll just see what that kidney's doing. They're not really supposed to be touched. You know, they're not designed for it. And this kidney feels like a rubber ball. Pretty springy. How's your digestion in general? Seem okay? Pretty trouble-free? Yeah. Okay. Okay, so I think I'm just going to say hello to the front of her shins and ankles just a little bit to kind of pick up balance of ligaments and muscles across the front of the joint. Then we'll go to the back of her legs. So this again is just picking up stitches from earlier sessions. How's the TV show? So once again, I'm taking more precaution with this line. The previous legwork has been much more about anatomy, biomechanics, but now I'm starting to push geometry. Right smack in the front, talus on tibia. But you see, I have my right hand on her calcaneus. Well, I would say it is moving. What happens is I put a load here. The calcaneus starts almost a swimming motile response. And that's just opening the system. So it's not like I'm trying to put it somewhere so much as open so it can adapt when we get these hamstrings and gastroc and soleus laying flatter on the back of her legs. This will be able to change. And this is the one that was out lateral. So I'm just going to see how that feels by comparison. Here it comes. Yeah, now I can feel how it goes lateral, like the way that pressure is on it internally. Oh, now it's going to come medial. It's almost, sometimes it's just recognizing how things are that lets them change. You know, it's a little bit like coming out of denial in psychotherapy. Like, oh, I've got a problem. As soon as you get there, you know, you're most of the way home. That's right. So, you know, there's nothing I can ask her to do that's going to make this happen more, because I'm actually getting an induced motile response. So I'm not, if I ask for a motor pattern over top of that, it's going to that'll shut down. Because then her proprioceptive pattern will overlay it. Deborah, will you give up your glass of water for medical science here? John, you could come a little more over here to get a little better line on that. You ever sprained this ankle? Yes.
Probably.
Uh-huh.
Yeah.
It sure has an awful lot of slack in this direction. See, the other one doesn't come that far, but this one feels like you might have walked off the side of it a couple of times. Maybe that's why that calcaneus is kind of parked out there. Would you lay on your belly for a few minutes?
I think it's from both ends.
Now, remember what I said about the neck? So this will just take some of the strain off your neck, so this stays open. Yeah. Scoot down to your feet, drop off the end. Okay. Well, that doesn't do you much good then, does it? Yeah. Okay. Raise up and let me put this under your, so your neck doesn't get cranked. Okay. So let's take a look at the soles of her feet with respect to how how they're patterned to receive that weight from above. Craig, I'm going to get right in front of you. It's right here. So one thing we see here is this whole lateral arch is quite far down. This suggests that when she's really using her lateral arches a lot more than the medial arch. And this is the one with the lateral calcaneus, and you can see the different set of the heel in relation to the foot. Remember how this one's pulled medial, and I said it looked like it operated inside of that tuberosity? Here it is. This one is outside the tuberosity. So part of the project of 6 is to begin to get this alignment working better. So the various technical approaches, are not so important, but this is the target goal, is this set of relationships for this section of the session. So if we can get this in place on both sides better, then when we come up and do ilium sacrum and then sacrum spine, this will all kind of be a pathway. So I go to work on this.
Dan, did you say the lateral for the arch of the foot closer to the face?
I didn't say that.
He said down.
Posterior or inferior. The whole foot is like pointing at you like that. Well, actually, they both are somewhat. But I want to try and get this whole thing more like this, if I force it that way. You can go headward one tiny hitch, Trish. Okay, good. Yeah, so you don't cool off there. Keep those kidneys warm. Speaking of warm kidneys, in the Orient, it's really common to just bind the abdomen with a long bolt of cloth. And then the rest of you stays warm. Then you can pump heat out to your extremities. But if you lose heat in those kidneys, boy, you is cold. Flannel, yep. So one thing, you can think of this as straightening out the socks. If you imagine she had on a sock that was kind of where the lay of the fabric was off, kind of, how you get your socks straight before you put your shoes on. Some of this. I think it's curious, although I don't quite know the meaning of how prominent the head of that 5th metatarsal is. It's almost, she's like got a callus on it. Say that again? Oh. Ouch. I'm just gonna mosey into that territory there and say hello. There's the remains of a blister there. If the monitor's turned so I can see it, I can help get the video more coherent. Sometimes it's just a matter of moving my hand a half an inch. Just a little. We don't want to ruin the TV show. There. Okay. Yeah. As I work in here, I can feel the pulls. Remember, the gastroc and the soleus both cross ankle and talus calcaneus, as well as the gastroc crossing the knee at this end. So this whole thing you think of as having continuity. Remember, I said at one point this is the equivalent of the back leg, in a quadruped. This is the back leg and this is the foreleg. So here's the look. It looks as though the whole gastroc is being pulled around, wrapped around the fibula here, bound up with the lateral ham on this side, whereas this line looks a lot easier. So it sort of informs me to begin to direct my attention over here more.
Try to give it some distinction.
Literally try to give this length.
Right.
Now, it doesn't have to be a thumb here. Fingers would do. An elbow. But I like the thumb. So, I'm thinking about that diamond. See that tissue start to migrate this way? Jeannie, can you see a difference in these two shapes?
Oh, I'm saying I'm amazed. Not that I don't.
Oh, I thought you were shaking your head no.
No, it's like, I can't believe we can do this stuff. No, it's just...
I have this tape of this great black gospel singer from the South, Reverend Cleavant Derricks. It's funky, down-home stuff, a cappella. And all he talks about is faith. Now, Trish, just bring your foot up on the ankle, just a little, and imagine you're going to bring it into the plane that it would be on with the ground. Okay, now go down like you're pushing off from a step. Flex your toe hinge a little bit. No, the other way, like you're pushing off. There. Now come up again. And down. Up. Oh boy. Yeah. So, when I'm driving in here, I'm actually getting into the soleus. I'm not going through the gastroc this way. I'm going under that head of the gastroc to pick up soleus tissue. You see here? We're getting better connection through. No, I'm still curious. And here's a great example of lack of horizontality in the fascia. You can actually see the diagonals in the fascial tissue like this. So what am I going to do? I'll go down the outside. So I'm going to push this diagonal like that.
Try and straighten it out.
And try and get the tissue to lay more like this.
Yeah, horizontal.
Once more, just a little help at the foot, Trish. Yeah. Okay, and let it go. Now push against me with the ball of your foot.
Kind of splitting up that gastroc.
Yep. Like you push me away. Yeah. Okay, great. That looks like what? Okay. A little bit more of that soleus stuff. Make you give you the wiggles there? Okay, I'll back off just a bit. Now come up with the foot, but just a little, and you'll feel it pull against what I have a hold of. Yeah, now come down same way. And up again. Down. Okay. Okay, good. I think it's going to work better. We got the diamond a little better. It's not perfect, but it's not, the whole thing's not being wrapped around to this side now. Let's come into this quadrant of it. Just find your foot just a little, Trish. Just put some tension in it. Yeah. So remember, the head of the gastroc comes up, and these are like this.
Interdigitated.
Yeah, actually overlaid. It's an interdigitation is usually like that. This is like this. And that bundle there, those hamstrings, is real tough. Now, it ought to be. So I have to go pretty slowly in there because there's a lot of thick, almost fascial tissue rather than muscular.
So are you differentiating the two?
I'm differentiating. Now, keep the foot like that, Trish, and then just raise the lower leg off the table just slightly. And back down. So now you're going to keep the foot, but do that little movement with the leg.
Here's put a penny.
Nope. Okay, very good. And let it go.
That made a big difference.
Yeah, that's better. I'm going to leave that lower leg alone. That's enough for that. But you can take a look at it from the end and look at the lines through the two legs. So you see how that leg lays straighter? So again, you know, you're working to a template. The outcome is not that you're going to get the perfect line, but you're moving toward a concept, toward geometry. Because geometry and structure never are the same thing. Okay, side two. I'm 35 minutes into this session. Oh, now the plantar fascia in here is very different than it was on the other foot. We need a commercial. You know, a little break in there for KY jelly or rubber gloves.
I like the table.
Yeah, adjustable tables. Again, I'm looking for it. Yeah, there. That plantar fascia is getting more springy now. So I'm looking for adaptability here as much as reshaping the sole of the foot. And there'll be plenty of people where you might give this 10 minutes of your time, you know, given that you might decide to distribute the session this way. But 10 minutes here is not 10 minutes somewhere else. Not in addition to the other hour and 15 you're going to do. Okay, now this heel gets the work on the outer aspect rather than the inner. Remember why? So this one I'm trying to get longer in here rather than there. You should probably turn it off when you're moving like that. You're when he walks around the table with the camera on the monitor, you know, he's just spinning, you know. A lot of that kind of grainy gristle in around these tendons. Oh, I know. That wasn't easy.
I know you were hard, but it just seems like it's really lined up.
Yeah. But that wasn't easy for me or for Trish. No, I'm kind of playing around the corner here. I don't know what I'm on. I should never confess these things. Yes, of course, I'm on the boundary here of the gastroc and the soleus and the... Well, the truth is you don't have to know anatomy to be a good rolfer. You do have to have an eye for form. Or I would have to say you either have to have an eye for form or you have to know your anatomy. You know, but it's not primary. I mean, really, it's about shapes, geometry, bringing form into spatial order. So, you know, you could run rolfing from a sculptural perspective and using the aesthetic. Uh-huh. Right. To develop an eye for form is really pretty important somewhere in the equation. And if you don't know anatomy and you don't have an eye for form, you should become a bureaucrat. You know, run an HMO. or get into politics, maybe. Oh boy, that's great. Now it's like this leg learned from the other one, because the whole response rate is much quicker. There you go. There you go. Now zoom on that baby. That's right. Yeah. I'm just feeling the way the lower leg tracks. Got some funny pulls right in here down low on the gastrosoleus. I think I'm going to let her get up and move around a little bit, and let's see where we are.
Catching up on my sleep.
You're sleeping?
No, I'm not sleeping.
I must be slipping if you're sleeping. So just feel your legs and feet as you move around. Just kind of check in down there. So we're looking at how her heels work in relation to the pelvis. Get any progress on that lateral calcaneus? Yeah. How about the anterior tilt of the pelvis? You know, it's interesting that her pelvis actually looks less anterior tilt in motion than it does standing still. This is important, because the truth is the body's a motion machine. It isn't about just standing still. Okay, let's head for the hamstrings. Same position. I'll start on this one. Now, people routinely complain that when you push into the back of the leg like this, the patella feels like it gets squirrely and wants to squirt out from under. So it's really important that you protect your client from that sensation, either by putting a pillow under here or by putting your hand in there. I prefer to use my hand like that. Yeah, well, the patella sits right here. So that keeps that sensation out of there. Okay, now, Trish, I need you to press your knees straight into the table. And now straight back, just like you're going to try and push me off. You got it. That's the feeling. Okay, and come back again. Now I'm pretty high focus here. This is elbow point, not flat. So there's differentiation going on. Weird to have everybody looking over there. It is, because the energy goes differently in the room. You know, when they're all watching TV while I'm working. Now, knee forward just a little, and knee back. And again, try to lift me out of the tissue. Straighten the back of the knee. That's it. Okay. That puts you on guard, doesn't it? Okay. Back just a bit. Push. Okay. Excellent. Now just release the pressure and then come back again. Now when you're working in hamstrings, this is very different than having the knee pulled up the way we've been doing it. Because here, as she moves, she's strong enough to just pop me right out of the layer I'm trying to be in. So it requires a lot of staying power and very careful negotiation between you and the client about how hard they push back, how hard you push in. You notice that as soon as I leaned on here, I don't know if you could feel it, but she sort of got very defended. Like, what's coming? So right here, I'm getting up under the edge of that gluteal fascia. Yeah. Now, Trish, on this one, I want you to rotate your leg outward. That's it. And in. And out. Whew, that's it. We're in there. Yep. Okay. I can really see the line. So this begins to organize the spine differently. So I want to get that far on the other leg, and then we can transition across into the ilium. It shows on the TV. You can actually see the leg get straighter. She can't quite see it from where she is. Leg on pelvis. Turn the knee out, turn the knee in this way. Long axis. Also, it's really important here that you use your right hand and your left hand symmetrically. If you try to always dominate with your dexterous side, you will end up a wreck doing this. Okay, now bring the knee straight back. Kind of push me out of there. Not with your heel, but with the back of your knee. There. You got it. Now let down a little bit, then come back to it again. Good.
Are you differentiating between this and lateral?
Oh, I'm just shape changing in there. Yes, I could say that. I'm differentiating. It's coming. Coming in. Okay, Trish, this one's going to be turning the leg in and out a little bit. So start that way. Right there, you feel it. Go slow right there. Let's negotiate here for a sec. No, but she's turning, making small in and out rotation movements here. And there was a point where she started to move and I could feel the trochanter kind of surfacing with external rotation. And there was a moment where I was in a bundle that could move if we went more slowly. So I had her hold that and just waited till that kind of spread out. Now, I must say that Trisha's got some tough legs. I'm earning my money here today.
You just sit and wait until you can wait for that thing?
Yeah, it takes patience and perseverance, in a sense, you know, just waiting and, you know, I feel a density there. If I go too quick over it, she'll push me out of the depth and I'll be just cruising over it. But to get a real shape change, I have to wait at the depth until her tissue opens and sort of, in a sense, carries me rather than my pushing it. It's kind of like the Zen of Rolfing, you know. Now I'm going to work close to your tailbone here for a couple minutes, getting into these big ligaments. And the sacrotuberous on her left is about twice the density of the right side. And this is probably also a function of this, the way the feet are lined up under the tubes. So preferred technique for sacrotuberous is not fingers, because your fingers just can't stay long enough for a ligament to change tone. So you need to be able to bring to bear weight without quavering and all that, and the elbow is the tool for that. It would be toward the groin ventrally. Pressure's moderate. Focus very high. Here. I'm an hour in, you see. That's better. Our sacrum's tracking a lot better. We've been in there a couple times already. There's a little discrepancy in the tone, however, of the ligament array. This will be sacroiliac ligaments. So I'm not trying to move her sacrum now. I'm just balancing the felt sense of the suspensory array.
Put a balance on the side.
Yeah. What's it look like? Yeah. She has a deep personal experience of these structures right now. Well, not actually the full point, but I'm actually using that part of the blade sort of just off the point to hook those ligaments.
So you can hook them and then bend down.
Yeah. So I'm sort of at a juncture here. Question how much work to do on her back. I definitely want to touch in on this area that she's chronically sore, but I'm not sure that I want to take the vertebrae by vertebrae journey up her back, high detail, because I'll cook her if I do. This has been a lot of input. Yes? Good. I'm glad I got something right. Come here, you devil. These controls.
Got it?
Ooh, how about that?
Are you just working on that erector bundle, trying to widen it out a little bit?
Yep, just trying to get it to spread out. Because she's bunched up in here.
Is that tied to that rib that was twisted?
Might be organized with the rib. It's just part of that whole lower array of the erectors.
Looking through the sound and then stopping and stuff like that.
Yeah, just sort of scanning the whole zone here. This is pretty tender stuff here too. Bring this arm up by your head more. Right into the top of the crest. Erectors, primarily. I'm working my way through a bunch of tissue that has, that's gone a little gristly and fibrous. It's not as hydrated and resilient as the other side. So I'm just working into the dry field here to get some irrigation down in the soil. And this, I'm working in there too. Her bony alignment feels pretty good to me in here now. Much less of that side bend that I was encountering early on. A little bit sore on that vertebra. Yeah? Right rotated. Spinous is off the midline this way. So I'm just pushing it. That's it.
So your back is kind of back. Toward the... Oh, it's that way? So you're pushing on the spinous process, not the transverse.
Yes, I'm breaking the rules. But you have to know what the rules are so you can break them. Okay, Trish, I want you to turn your tail toward the ceiling ever so slightly. Back bending. And see if she's rotated right. This is relatively forward bent. So when I put her in back bending and push, maybe I can get these to close. Just your tail, don't grab with where I'm holding. There. Yeah. Okay, great. Okay. Yeah. Okay, I want you to turn onto your back. I'm going to take the pillow out from under you. And come toward me. Okay. Hour and 10. Oops, you want to move over a little? Okay.
So can you effectively check the sacrum that way as you can sitting on that? Appears pretty good.
Yeah. Remember, I've said over and over, the position is not as important as your understanding of what is the normal. You know, you're understanding the pattern.
Good job. Good shot.
This one?
That's great. Yeah, I like it to really see the
You can't see the ones that are doing the job. We need a mirror here. Would that be cool, a translucent tabletop? You know, the camera looking from under?
Even having somebody walk on it. On a little track underneath.
No, there's progress in her neck. She's not carrying as much hard, deep tension. And rather than sort of get in here, I think I want to leave most of her circulation resource down there. Next session, all head and neck. Okay, I think we're there. I want you to get up and move around a bit, see how it is. Deborah, when do you do your next movement session?
Monday.
Next Monday. Yeah. Okay, need to do just a little fine tuning. Come on over here for a second. I have to use my feet on you. Stand right in front of me. Put your big toes right opposite mine. And so your big toe and ankle are touching. So close up. Yeah, like that. This is just to bring everything into alignment. So now, wait. Stick your tail out. More. More. There. Now, bring your chest over my head a bit, like you're skiing downhill. Yeah. That's it. Now, very slowly go tall. And straighten your knees. Don't back bend. Okay, great. Take that walk again now. That's a little less funny. She's in a state from this. Come back again. Same thing. Now bring your chest toward me. And now, from there, stick your tail out. Drop into your knees.
You doing shoulders?
Let your shoulders come forward a little more. Yes. Iliacus, psoas. Okay, now go back up. Okay. And walk again. See the push-off motion? Watch your pelvis go into that anterior torque as she pushes off. Keep going for a sec. Yeah. Okay, I'm going to leave you alone for now. Thank you.
Sit outside.
Yeah, be careful driving. Give yourself a chance to settle. You know, drink your juice. Bye now. Any questions or